Concept 19, gas exchange. Learning objectives. Define and describe the concept. Notice risk factors for impaired gas exchange. Recognize when an individual has compromised gas exchange. Provide appropriate nursing and collaborative interventions for optimizing gas exchange. Gas exchange is defined as the process by which oxygen is transported to cells and carbon dioxide is transported from cells. This normal physiological process requires interaction among the neurologic, respiratory, and cardiovascular systems. The lungs deliver oxygen to the pulmonary capillaries, where it is carried by hemoglobin to cells. After cellular metabolism, carbon dioxide is carried in hemoglobin to the lungs, where it is exhaled. Thus, adequate functioning of these systems is essential for optimal gas exchange. Several other terms are important as well. Ischemia means insufficient flow of oxygenated blood to tissues that may result in hypoxemia and subsequent cell injury or death. Hypoxia is insufficient oxygen reaching cells, whereas anoxia is the total lack of oxygen in body tissues. Hypoxemia is reduced oxygenation of arterial blood. Scope and categories. The process of gas exchange includes breathing, which is involuntary because changes in ventilation rate and volume are stimulated and regulated automatically by the nervous system to maintain arterial blood gases within normal ranges. Chemoreceptors in the medulla in the brain sense carbon dioxide levels, and when carbon dioxide concentration is elevated, these receptors transmit impulses to the diaphragm and intercostal muscles to contract. As the diaphragm contracts, negative pressure pulls in 21% oxygen from the atmosphere. The nose warms and humidifies the air, which flows to alveoli through patent airways, including the trachea and bronchi. Alveolar walls are lined with a single layer of epithelial cells called type 1 alveolar cells that provide structure. In between these types of cells, type 1 are thicker type 2 alveolar cells that produce surfactant, a lipoprotein that coats the inner surface of alveoli to keep them open. The high pressure of oxygen in alveoli causes it to diffuse into pulmonary capillaries, where it dissolves into the plasma and attaches to hemoglobin and erythrocytes to be transported or perfused to cells. Oxygen dissolved in plasma is measured clinically by the partial pressure of oxygen in the artery, or PaO2. Oxygen attached to hemoglobin is measured clinically by the saturation of arterial hemoglobin, or SaO2. At the cellular level, oxygen is released from hemoglobin, which is called hemoglobin desaturation. Oxygen dissolves in plasma and diffuses into the interstitial space, and then diffuses into cells to be used in metabolic processes. Carbon dioxide, a byproduct of cellular metabolism, is transported to the atmosphere in the reverse order of oxygen and lowers the arterial carbon dioxide level. The high pressure of the carbon dioxide in cells causes it to diffuse into plasma, which is measured clinically by the partial pressure of carbon dioxide in the artery, or PaCO2. When the amount of PaCO2 decreases, it turns off signals to the medulla to initiate inhalation until the carbon dioxide level rises again to repeat the gas exchange process. The term gas exchange can be misinterpreted because the word exchange can mean swap, substitute, or trade. However, as described by Dalton's law of partial pressures, the pressure exerted by each gas is independent of the pressure exerted by other gases. Oxygen diffuses from the alveoli to the pulmonary capillaries because the pressure of oxygen in the alveoli is higher than the pressure of oxygen in the capillaries. Gases diffuse from areas of high concentration to areas of low concentration. The belief that oxygen diffuses based on the diffusion of carbon dioxide is incorrect. These two gases are independent, they do not exchange with each other. Ventilation is the process of inhaling oxygen into the lungs and exhaling carbon dioxide from the lungs. Ventilation may be impaired by the unavailability of oxygen, such as at high altitudes, as well as by any disorder affecting the nasopharynx and lungs. Impaired ventilation may occur in the following situations: inadequate bone, muscle, or nerve function to move air into the lungs, such as a rib fracture that reduces inhalation due to pain, muscle weakness that prevents full thoracic expansion, or cervical spinal cord injury that limits movement of the diaphragm. Narrowed airways from bronchoconstriction, like asthma, or from obstruction, as in chronic bronchitis or cystic fibrosis, is another example of impaired ventilation. Poor gas diffusion in the alveoli, such as in pulmonary edema, acute respiratory distress syndrome, or pneumonia, is another ventilation problem. Clinical manifestations depend on the area affected, but individuals must work harder to breathe or must change the route by which air enters the lungs. When individuals have edema of the sinuses, they are unable to breathe through the nose. Instead, they breathe through the mouth until the edema subsides. Transport. Transport refers to the availability of hemoglobin and its ability to carry oxygen from alveoli to cells for metabolism and to carry carbon dioxide produced by cellular metabolism from cells to alveoli to be eliminated. Altered transport of oxygen occurs when an insufficient number or quality of erythrocytes is available to carry oxygen, or when the amount of hemoglobin in the blood is low. This occurs when patients have anemia for any reason. Blood loss from acute or chronic causes reduces the number of erythrocytes, thus making hemoglobin unavailable to carry oxygen. Finally, destruction of erythrocytes occurs in hemolytic anemias when the spleen destroys these cells prematurely, such as in sickle cell crisis. Perfusion refers to the ability of blood to transport oxygen-containing hemoglobin to cells and return carbon dioxide-containing hemoglobin to the alveoli. Inadequate or impaired perfusion can be caused by decreased cardiac output, as well as by thrombi, emboli, vessel narrowing, vasoconstriction, or blood loss. Physiologic processes and consequences. Again, the process of gas exchange includes breathing, which is involuntary because changes in ventilation rate and volume are stimulated and regulated automatically by the nervous system to maintain arterial blood gases within normal range. Chemoreceptors in the medulla sense carbon dioxide levels, and when carbon dioxide concentration is elevated, these receptors transmit impulses to the diaphragm and intercostal muscles to contract. As the diaphragm contracts, negative pressure pulls in 21% oxygen from the atmosphere. The nose warms and humidifies the air, which flows to alveoli through patent airways, the trachea and bronchi. Alveolar walls are lined with a single layer of epithelial cells called type 1 alveolar cells that provide structure. And between these type 1 cells are thicker type 2 alveolar cells that produce surfactant, a lipoprotein that coats the inner surface of alveoli to keep them open. The high pressure of oxygen in alveoli causes it to diffuse into pulmonary capillaries, where it dissolves into the plasma and attaches to hemoglobin and erythrocytes to be transported or perfused to cells. Oxygen dissolved in plasma is measured clinically by the partial pressure of oxygen in the artery, or PaO2. Oxygen attached to hemoglobin is measured clinically by the saturation of arterial hemoglobin, or SaO2. At the cellular level, oxygen is released from hemoglobin, which is called hemoglobin desaturation. Oxygen dissolves in plasma and diffuses into the interstitial space, and then diffuses into cells to be used in metabolic processes. Carbon dioxide, a byproduct of the cellular metabolism, is transported to the atmosphere in the reverse order of oxygen and lowers the arterial carbon dioxide level. The high pressure of the carbon dioxide in cells causes it to diffuse into plasma, which is measured clinically by the partial pressure of carbon dioxide in the artery, or PaCO2. When the amount of PaCO2 decreases, it turns off signals to the medulla to initiate inhalation until the carbon dioxide levels rise again to repeat the gas exchange process. Again, the term gas exchange can mean swap, substitute, or trade. However, as described by Dalton's law of partial pressures, the pressure exerted by each gas is independent of the pressure exerted by other gases. Oxygen diffuses from the alveoli to the pulmonary capillaries because the pressure of oxygen in the alveoli is higher than the pressure of oxygen in the capillaries. Gases diffuse from areas of high concentration to areas of low concentration. The belief that oxygen diffuses based on the diffusion of carbon dioxide is incorrect. These two gases are independent. They do not exchange with each other. Age-related differences. Babies born after 30 weeks of gestation have a sufficient surfactant to prevent alveoli from collapsing after every exhalation. Infants are obligate nose breathers until approximately 3 months. Should their nasal passages become occluded, they may have difficulty breathing. Sneezing occurs commonly as a way to clear the nose. Respiratory patterns for newborns may be irregular, with brief pauses between breaths no more than 10 to 15 seconds. For older adults, diminished strength of respiratory muscles reduces the maximal inspiratory and expiratory force. This may result in a weaker cough. The alveoli become less elastic and more fibrous, causing dyspnea more frequently. Older adults experience a reduction in erythrocytes, which increases their risk of anemia. We discussed ventilation, transport, and perfusion in an earlier slide. The pathophysiology depends on the extent of impairment in terms of gas exchange. Because adequate gas exchange is required for life, regardless of age, gender, race, or socioeconomic status, potentially anyone are at risk for gas exchange impairment. Nurses need to recognize, however, some individuals are at greater risk for impairment. When gas exchange is compromised for any reason, a reduction or cessation of oxygen occurs that affects the cells, triggering a number of physiological problems depending on the extent of impairment. With mild impairment, an individual often experiences fatigue. This system actually helps the body compensate through rest, thus reducing oxygen demand. Heart rate and respiratory rate also may increase in an attempt to increase oxygen delivery to cells. When impaired gas exchange becomes more pronounced, a reduction of oxygen at the cellular level leads to reduced mitochondrial respiration and oxidative metabolism. Carbon dioxide transport from the cells to the alveoli leads to a buildup of acid. Thus, when the underlying problem is associated with ventilation, respiratory acidosis may result. Metabolic acidosis can occur if the underlying problem is associated with transport or perfusion. If the impairment is prolonged or severe, cellular ischemia and necrosis can occur. A complete cessation of gas exchange occurs when breathing or perfusion stops and quickly results in death. Populations at risk. Populations at greatest risk are infants, young children, and older adults. Infants are at risk because they have fetal hemoglobin. Fetal hemoglobin is present for the first 5 months of life and results in shortened survival of erythrocytes, causing physiological anemia by age 2 or 3 months. Contributing to anemia at approximately 6 months of age is the lower level of hemoglobin caused by gradually diminishing maternal iron stores. Infants and young children are at risk for impaired gas exchange because they have less alveolar surface area for gas exchange, as well as narrow branching of peripheral airways that are easily obstructed by mucus, edema, or foreign objects. Older adults are at risk for impaired gas exchange because of anatomic and physiological changes that are expected with advanced age. The chest wall becomes stiffer with loss of elastic recoil. Respiratory muscles become weaker, reducing the effectiveness of coughing, normally a protective mechanism to prevent aspiration. Additional expected changes are dilation of alveoli, decreased surface area for gas diffusion, and decreased pulmonary capillary network. Finally, the ability to initiate an immune response to infection is decreased in older adults. Individual risk factors. A number of personal risk factors are linked to impairment in gas exchange. Non-modifiable risk factors include age, air pollution, and allergies. Tobacco use is the single most preventable cause of death and disease in the U.S. and is the most significant risk factor for impaired gas exchange. The percentages in each of the 5 categories in box 19.2 on page 181 in concepts have decreased over the last few years, indicating fewer people smoking. Risk for aspiration is increased during an altered state of consciousness as from a chemical alteration, such as alcoholism, drug overdose, and anesthesia, or from a neurologic disorder such as a head injury, seizure, and stroke. Patients requiring tracheal intubation are at risk because of the bypassing of protective mechanisms for the alveoli. Bed rest and prolonged immobility reduce thoracic expansion, which can increase the risk for atelectasis and pneumonia. Chronic diseases such as cystic fibrosis, COPD, or heart failure increase risk because of mucus and fluid accumulation in the airways and alveoli. Immunosuppression alters the body's natural ability to fight infection, whether it is from a systemic disorder such as aplastic anemia, or cancer such as leukemia, or a treatment regimen such as cancer chemotherapy. Assessment. Nurses gather data from the patient's history, physical exam, and the patient's diagnostic test results. Assessment of gas exchange involves recognizing indications of adequate and inadequate ventilation, transport, and perfusion. Adequate ventilation is apparent when the following occurs. Breathing is quiet and effortless at a rate appropriate for age. Oxygen saturation, SaO2, is between 95 and 100%. Skin, nail beds, and lips are appropriate colors for the patient's race. Thorax is symmetric with equal thoracic expansion bilaterally. Spinous processes are in alignment. Scapula are bilaterally symmetric. Anterior-posterior AP diameter of the chest is approximately a 1:2 ratio of AP to lateral diameter. Trachea is midline, and breath sounds are clear bilaterally. The nurse needs to get a baseline history. When collecting subjective data from patients, nurses ask about lifestyle behaviors, including diet, exercise, and smoking. Nurses ask about patients' work and home environments to identify potential respiratory irritants. Also, patients are asked about any chronic diseases as well as allergies that may affect the respiratory system. Nurses ask patients about medications they take, both prescription and over-the-counter, and the reason each medication is taken, as well as its efficacy. Problem-based history. The following symptoms are often reported by individuals experiencing gas exchange impairment: cough, shortness of breath, and chest pain. When a symptom is reported, a symptom analysis is conducted. Cough. When a cough is reported or observed, the patient should be asked if the cough causes fatigue or interferes with sleep. The patient should also be asked if the cough is productive or non-productive. Ask about the color and consistency of productive coughs. Question the patient about factors that aggravate and alleviate the cough, as well as any self-treatment measures taken to relieve the cough. Also, the patient should be asked about other symptoms that accompany the cough, such as fever or shortness of breath. Shortness of breath. Patients may report they have had to stop climbing stairs to catch their breath. Others may report having to sleep sitting up or using several pillows to prop themselves up during the night. Lightheadedness may be reported as a result of inadequate oxygen transport to the brain. Inquire about what precipitated the shortness of breath, and if it occurs during inhalation or exhalation or both. The patient should be asked what factors aggravate and alleviate the shortness of breath, and also if there are any other symptoms, such as cough, chest pain, or swelling of the feet and ankles. Chest pain with breathing. The patient should be asked what activity is associated with the chest pain, when it occurs, and how long the pain lasts. Ask if the onset of chest pain was gradual or sudden, and ask for a description of the pain, such as sharp or dull, pain radiating, and severity. Vital signs. Inadequate gas exchange is noticed by changes in vital signs such as an increase in respiratory rate, decrease in SaO2, increase in heart rate, and increase in temperature. An increased respiratory rate may be due to increased work of breathing. The SaO2 level value may drop below 95% when oxygen is not being transported by hemoglobin to cells. Tachycardia may occur either from anxiety caused by not being able to breathe well or from anemia. Temperature may be elevated because of an infection such as pneumonia or respiratory syncytial virus, otherwise known as RSV. Inspection. If a patient is having difficulty breathing, the nurse may notice the patient assuming a position to ease the work of breathing, sitting, leaning forward. Patients with impaired gas exchange often appear anxious because of the sensation of not getting enough air or a feeling of suffocation. Low oxygen saturation may impair mentation as a result of lack of adequate oxygen supply to the brain. Patients may use accessory muscles on inspiration to help get air into the lungs. They may use pursed lip breathing on exhalation to keep airways open longer. The skin and lips may appear pale because of anemia or hypoxemia. A late sign of hypoxemia is cyanosis. Clubbing of nails develops in patients with chronic hypoxic disorders such as cystic fibrosis or COPD. When patients develop a barrel chest from air trapped in alveoli from emphysema, their antero-posterior to lateral diameter ratio changes from a normal of 1:2 to 1:1. The thorax may be asymmetric with unequal thoracic expansion, unilaterally attributable to pneumothorax. Scoliosis is a curvature of vertebrae that creates asymmetric expansion of the thorax, as well as malalignment of spinous processes and scapula. The trachea shifts from midline away from the lung that is experiencing a tension pneumothorax. Additional assessment findings commonly noted in infants and young children with inadequate gas exchange are flaring of the nares, chest wall retractions on inspiration, grunting on inspiration, cyanosis around the lips when sucking, and the need to stop during feeding to breathe. Auscultation. During auscultation, narrowed bronchi may produce expiratory and or inspiratory wheezing or stridor. Mucus or secretions in the bronchi may create rhonchi, and fluid in alveoli may generate crackles. Diagnostic tests. There are a number of diagnostic tests associated with gas exchange that are used to assess for impairment. Arterial blood gases. Reveal measurements of pH, oxygen, carbon dioxide, and bicarb concentrations in arterial blood. They are used to detect respiratory acidosis and alkalosis. Respiratory acidosis develops during hypoventilation when carbon dioxide is retained, such as in patients with COPD. Respiratory alkalosis develops during hyperventilation when excessive carbon dioxide is inhaled, such as during anxiety or hysteria. Arterial blood gases reveal measurements of pH, oxygen, carbon dioxide, and bicarbonate concentrations in arterial blood. They are used to detect respiratory acidosis and alkalosis. Respiratory acidosis develops during hypoventilation. Respiratory alkalosis develops during hyperventilation, also when excessive carbon dioxide is exhaled, such as during anxiety or hysteria. Arterial blood gases include the following measures. pH should be between 7.35 and 7.45. Values less than 7.35 indicate acidosis, and values greater than 7.45 indicate alkalosis. SaO2 is an abbreviation for saturation of arterial oxygen and represents the percentage of arterial hemoglobin that is saturated with oxygen. This value accounts for approximately 97% of arterial oxygen. The normal value for adults is 95 to 100%, and for newborns, 40 to 90%. PaO2 is an abbreviation for the partial pressure of arterial oxygen and represents the pressure of oxygen dissolved in arterial blood. This value accounts for approximately 3% of oxygen. The normal value for adults is 80 to 100, and for newborns, 60 to 70. PaCO2 is an abbreviation for the partial pressure of arterial carbon dioxide and represents the pressure of carbon dioxide dissolved in arterial blood. The PaCO2 is a measurement of ventilation capability. The normal value for adults is 35 to 45, and for children younger than age 2, 26 to 41 millimeters mercury. Bicarb HCO3 is an abbreviation for bicarbonate and represents most of the carbon dioxide in the blood. Normal values are 22 to 26 milliequivalents per liter. There is a direct proportional relationship between bicarbonate concentration and pH. Thus, when bicarbonate concentration is above normal, the pH increases, indicating alkalosis. When the bicarbonate concentration is below normal, the pH decreases, indicating acidosis. The kidneys compensate for primary respiratory acid-base alterations. For example, in respiratory acidosis, the kidneys compensate by retaining bicarbonate in an attempt to regain acid-base balance. However, in respiratory alkalosis, the kidneys compensate by excreting bicarbonate in an attempt to regain acid-base balance. Complete blood count. The complete blood count is obtained from venous blood and includes measurements of red blood cell count, called RBCs, hemoglobin, HB, hematocrit, HCT, and white blood cells, WBC. Red blood cell count determines the oxygen carrying capacity of the blood. Each red blood cell carries hemoglobin that transports oxygen to tissues and carbon dioxide from tissues. Patients who have anemia have decreased numbers of red blood cells, which reduces the patient's oxygen carrying capacity. Hemoglobin levels reflects the number of red blood cells in the venous blood and determines the oxygen and carbon dioxide transport capability. Hematocrit, known as HCT, measures the percentage of venous blood volume that is composed of red blood cells. The hematocrit closely reflects the hemoglobin and the red blood cell values. WBC, white blood cell count, measures the number of leukocytes in venous blood. The WBC differential measures the percentage of each leukocyte, such as neutrophils, eosinophils, basophils, monocytes, contained within the total number of WBCs. Elevations in total WBC count occur when there is inflammation, and often the inflammation is due to infection. Decreases in white blood cell count occur with certain cancers and as an adverse effect of chemical or radiation therapy to treat cancer. Patients with low WBC counts are at risk for newly acquired infection because the immune system is unable to respond optimally. The WBC differential is helpful in suggesting a generalized cause of the abnormal value. For example, elevated neutrophils indicate an acute inflammation, whereas increased monocytes indicate a chronic infection. Eosinophils are elevated during allergies. Sputum examination. Studying sputum specimens can help in the diagnosis of respiratory disorders. Culture and sensitivities are performed on a single specimen to detect bacteria and determine which antibiotic is the most effective. Gram stain of sputum distinguishes gram-positive from gram-negative bacteria. Testing a series of 3 early morning sputum samples for acid-fast bacillus is diagnostic for tuberculosis. A single sputum specimen for cytologic examination is performed to detect a pulmonary malignancy. Skin tests. MAN2 tests for tuberculosis. A positive reaction to the skin test indicates the patients have developed antibodies to Mycobacterium tuberculosis. Allergies detected by skin tests may indicate causes of bronchoconstriction. The sweat chloride test screens for cystic fibrosis, which produces high levels of chloride in the sweat. Pathologic analysis. Tissue from the lungs or bronchus may be taken for pathologic analysis, especially if a malignant tumor is suspected. Chest x-rays are very useful in detecting impaired ventilation because they provide visualization of the lungs, ribs, clavicles, vertebrae, heart, and major thoracic vessels. They are useful in identifying foreign bodies, infiltrations in pneumonia, tubercles and tuberculosis, tumors and cancer, or edema. In patients with COPD, chest x-rays show the flat diaphragm and barrel chest configuration of ribs and vertebrae. Also, chest x-rays can identify pleural effusion, pneumothorax, hemothorax, or empyema. CTs, scans of the chest produce three-dimensional images of the lungs and are useful for detecting pulmonary densities, space-occupying tumors, and pulmonary emboli. VQ, or ventilation perfusion scans, use radioactive particles to diagnose disorders involving both perfusion and ventilation. Radioactive particles are injected into peripheral veins to detect impaired perfusion to the lungs. Also, inhaled radioactive particles are used to detect impaired lung function. This scan is used to diagnose pulmonary emboli. Positron emission tomography, called PET, positron emission tomography scans use intravenous injection of radioactive chemical compounds to distinguish benign from malignant pulmonary nodules. Pulmonary function tests assess the presence and severity of diseases in large and small airways. A spirometer measures the volume of air moving in and out of the lungs and then calculates the lung capacities. One example of its use is for patients with asthma. Because their bronchoconstriction can worsen, they exhale less air. This finding is reported as decreased forced expiratory volume. Pulmonary function tests are also used to distinguish between obstructive and restrictive pulmonary disease. Because air trapping increases for patients with obstructive lung disease, such as cystic fibrosis or COPD, more air remains in their lungs, which is reflected as an increase in reserve volume. Obstructive lung disease impairs patients' ability to get air out of the lungs. By contrast, patients may develop restrictive lung diseases from intrapulmonary or extrapulmonary causes. Intrapulmonary causes include pulmonary fibrosis or empyema. Extrapulmonary causes include chest wall trauma or cervical spinal cord injury. Restrictive lung diseases impair the patient's ability to get air into the lungs, as reflected in a decrease of tidal volume. Endoscopy. Bronchoscopy is an endoscopy examination in which a flexible fiber optic bronchoscope is extended through the bronchi for the purpose of diagnosis, specimen collection, or tissue biopsy. Primary prevention. Immunizations prevent infection by bacteria or viruses such as diphtheria, Haemophilus influenza type B, H1N1, flu, influenza, measles, pneumococcal pneumonia, pertussis, and rubella. Schedules for these immunizations from infancy to adulthood are found on the Centers for Disease Control and Prevention website. Preventing postoperative pulmonary complications. After a surgical procedure, patients are encouraged to deep breathe and cough at least every 2 hours and/or use an incentive spirometer to prevent pneumonia and atelectasis. This device encourages deep breathing for patients and measures the air inhaled as an outcome indicator that is useful for nursing assessment. Preventing deep vein thrombosis is essential for all patients who are less active than usual so that pulmonary emboli are prevented. This includes patients after a surgical procedure or those whose disease process prevents them from ambulating as much as usual. One intervention is to subcutaneously administer an anticoagulant to reduce clotting of platelets. Another intervention is to apply elastic stockings to the legs or use intermittent compression devices to the lower legs to prevent venous stasis. A third intervention is to encourage ambulation as soon as possible. Secondary prevention screening. Collaborative interventions. Smoking cessation, is typically considered primary prevention to prevent respiratory illness. It is also considered an important intervention strategy among individuals who have a disease process because smoking exacerbates respiratory and cardiovascular disease. Pharmacotherapy. Pharmacotherapy plays a very important role in managing individuals with impaired gas exchange. Agents can be used to open upper and lower airways to improve gas exchange by dilating airways, reducing edema, increasing a cough's effectiveness, and killing or limiting the growth of microorganisms. Depending on the pharmacological agent, these drugs are administered through a number of routes, including oral, intravenous, and inhalation through inhalers or nebulizer machines. Drugs that affect upper airways. Antihistamines relieve symptoms of sneezing, rhinorrhea, and nasal itching experienced in allergic rhinitis. They are more effective when taken prophylactically. Antihistamines block the histamine receptors to cause vasoconstriction and decrease capillary permeability of small arterioles and venules. Decongestants relieve congestion in passageways and sinuses. Intranasal glucocorticoids exert an anti-inflammatory effect to prevent or suppress major symptoms of allergic rhinitis, such as congestion, rhinorrhea, sneezing, nasal itching, and erythema. Sympathomimetics act as decongestants by activating the alpha adrenergic receptors on nasal blood vessels to cause vasoconstriction that shrinks edematous membranes, thereby reducing nasal drainage. Lower airway bronchodilators. Glucocorticoids reduce bronchial hyperactivity that occurs in asthma. Oxygen therapy. Delivery of humidified oxygen is a cornerstone of gas exchange intervention. Nurses collaborate with respiratory therapists to supply patients with oxygen and teach them how to use oxygen at home when needed. Oxygen therapy is provided through a variety of delivery mechanisms when patients require more than 21% oxygen. A nasal cannula is used to deliver 24% oxygen at flow rates of 1 liter per minute to 44% oxygen at flow rates of 4 liters per minute through plastic nasal prongs. This is a safe and simple method that is used for long-term therapy. The cannula allows patients to eat, talk, and cough while wearing this device. Patients whose pulmonary disease causes restriction of carbon dioxide, such as those with COPD, should not use oxygen levels greater than 3 liters per minute. Their bodies have adjusted so chronically high levels of carbon dioxide, called hypercapnia, so that carbon dioxide no longer acts as the stimulant to breathe. For these patients, low blood oxygen levels become the stimulant to initiate breathing. Thus, giving these patients oxygen at more than 3 liters can eliminate their stimulus to breathe, causing hypoventilation and, if prolonged, death. Another oxygen therapy device is a simple mask that covers the patient's nose and mouth. This mask delivers between 35 and 50% humidified oxygen at flow rates of 6 to 12 liters per minute and is used for short-term therapy because of its uncomfortable fit. Partial or non-rebreathing masks are used for short-term therapy when patients need higher levels of humidified oxygen between 60 and 90% at flow rates of 10 to 15 liters per minute. Oxygen flows into a reservoir bag and mask during inhalation. To attain these high levels of oxygen, the mask must fit snugly over the nose and mouth and may be uncomfortable. Venturi masks can deliver precise high flow rates of humidified oxygen. These lightweight cone-shaped devices are fitted to the face and are able to deliver 24, 28, 31, 35, 40, and 50% oxygen. These masks are used to deliver low-flow, constant oxygen concentrations to patients with COPD. Oxygen delivery devices, such as tracheostomy collars, are available to provide humidified oxygen to patients with tracheostomy tubes. Airway management and breathing support. Patients with an acute disorder causing impaired gas exchange may need airway support. Before arrival of the emergency team, the nurse may insert an oropharyngeal airway to maintain the patient's breathing. Patients may require intubation using an endotracheal tube or tracheostomy tube. Humidified oxygen is delivered to the trachea and bronchi. When breathing support is needed, the patient's respiratory rate and volume are controlled by a ventilator. Chest physiotherapy and postural drainage. Chest physiotherapy and postural drainage are performed for the purpose of loosening and moving secretions into large airways where they can be expectorated. Chest physiotherapy includes percussion, which is cupping and clapping, and vibration to loosen secretions. Postural drainage involves positioning the patient in specific positions, head down on left and right sides, and supine and prone, to use the benefit of gravity to remove secretions after they are loosened from specific segments of the lungs. Patients with cystic fibrosis use this procedure frequently to help remove the thick secretions formed by their disorder. Invasive procedures include chest tubes, thoracentesis, and bronchoscopy. Chest tubes are placed in the pleura to remove air, such as in a pneumothorax, and or blood, as in a hemothorax, so that the lungs can be re-expanded after thoracic surgery or trauma. Nurses monitor the amount and appearance of drainage from chest tubes and change the dressing around these tubes as ordered. Thoracentesis is a procedure to relieve a pleural effusion by inserting a needle into the pleural space to remove fluid. Nurses assist providers with this procedure and monitor the patient's vital signs, lung sounds, and pain level afterward. Bronchoscopy is a procedure that can be diagnostic or therapeutic. The procedure involves insertion of a bronchoscope through the trachea into the bronchi. The diagnostic effect is directly visualizing the airway or taking tissue samples for biopsy. The therapeutic effects can be including removing foreign objects and suctioning mucus plugs from airways or lavaging airways. Airway patency can also be accomplished using laser therapy, electrocautery, cyrotherapy, and stents placed through a bronchoscope. Nutrition therapy is needed to provide energy for the increased work of breathing and to support the immune system. High protein, high calorie, nutritious foods and drinks meet the needs of these patients. Small meals are advised for patients who become dyspneic while eating. For patients with a productive cough, oral care should be offered before meals to reduce any lingering taste of sputum. Positioning. Two positions are important interventions for patients with impaired gas exchange. The first position is sitting up. Patients with acute or chronic impaired gas exchange breathe more easily in high Fowler's position, or semi-Fowler's position. These positions use gravity to move the diaphragm away from the lungs to reduce the work of breathing. Orthopnea refers to an abnormal condition in which a person must sit or stand to breathe comfortably. Patients with chronic pulmonary disease may use a tripod position or prefer sleeping while leaning forward over a table. The second position is lying horizontally, which helps patients who are hypoxemic and have acute lung disease. The distribution of pulmonary capillary blood flow is affected by gravity in different body positions. The greatest volume of pulmonary blood flow occurs in the gravity-dependent areas of the lung. The areas of the lung that are most dependent become the best ventilated and perfused. Although thoracic expansion of the dependent lung is reduced somewhat by the mattress, the gravity-dependent lung still has better ventilation and perfusion than the other lung. Other interventions: alternate activity with rest periods. For example, if the patient becomes dyspneic after a bath or shower, allow a rest period before a meal or exercise. Many patients with COPD perceive they can breathe easier when there is an increase in air circulation, which they can accomplish by using an electric fan. Patients' coping may be improved by encouraging them to express their feelings about their impaired gas exchange and how it has changed their lives. Nurses may be able to help patients locate needed resources. Types of medications. Antihistamines block histamine receptors, and they are used for sneezing, rhinorrhea, and nasal itching. Decongestants are anti-inflammatory, transnasal. They prevent or suppress allergic rhinitis. Sympathomimetics cause vasoconstriction with people that need decongestants. Bronchodilators, such as glucocorticoids and sympathomimetics and anticholinergics, anticholinergics are used. Glucocorticoids suppress inflammation. Sympathomimetics relax bronchial smooth muscles, such as bronchospasm. Anticholinergics can cause bronchodilation to help the patient breathe easier. Mucolytics liquefy mucus to help them produce sputum, and expectorants are used for promoting productive cough. Cough suppressors are used to help them rest or sleep. Antibiotics are used to fight any bacteria infections, and smoking cessation. We need to use nicotine replacement therapy. Clinical invasive procedures mentioned earlier. Chest tubes remove air and or blood or fluids from the lung. Thoracentesis is used for a fluid in the lung specifically. Bronchoscopy to take samples or to open an airway. Endotracheal tubes and tracheostomy tubes so that the patient can breathe with an alternate method, and mechanical ventilation if they're unable to use their diaphragm for breathing. Positioning for the air impaired patient is high followers, sitting up. Also for orthopnea, at night, sleeping, people need to be sitting up, and they generally use a tripod position, sitting up and kind of leaning forward a little bit to open the lungs. Also supine, lying horizontally, with acute lung disease and hypoxemia will cause the greatest pulmonary flow to the opposite side. Interrelated concepts include anxiety, acid-base balance, perfusion, fatigue, mobility, and nutrition. An abnormally low number of circulating red blood cells, a low level of hemoglobin, or both is it anoxia, anemia, leukocytosis, or erythrocytosis? You should have answered anemia, number 2. What is the single most preventable and significant risk factor for impaired gas exchange? Is it alcohol consumption, obesity, infection, or tobacco use? And your answer should be tobacco use. During auscultation, what sounds may be heard when there is mucus or secretions in the airway? Is it wheezing, stridor, rhonchi, or crackles? And you should have answered which.